space, what will happen is that they will not be dying. So, in the mass casualty incident, our job is to decide that we have to go for giving greatest good for the patients who are likely to get benefit from the medical interventions, that is the red patients. But one more thing is there. There is something called a large scale disaster. For example, there is a large scale massive earthquake happened. There is a nuclear disaster that is happening. So frankly, there I don't have resources or manpower or supplies where I can manage even the red patients. So there, my job is to do greatest good for greatest number of potential survivors. So just see, for day-to-day emergencies, we have to focus on each and individual patient. For mass casualty incidents, which we are discussing today, for example, which can be manageable, so we'll try to focus on the red patients. But in a large scale disaster, which is out of control of everything, it's very difficult to manage. So we'll try to focus on potential survivors. So here we are in the middle of something which is called as mass casualty incident. So this is what we'll be discussing today. Now, triage. Frankly, you must be knowing, you may be aware of the fact that there are a lot of triage system that is available, specifically in the normal scenario. For example, emergency severity index, which is common in United States. Manchester triage protocol, again, common in United States and United Kingdom and European countries. Australasian triage scale, which is specifically for Australia and New Zealand areas. So specifically, there are a lot of triage system, but what India follows, what AIIMS Delhi follows, what National Triage Protocol is, we follow something called as 3-tiered color-coded triage, that is red, yellow, and green. But if we try to apply those triage system in the mass casualty, it will be a horrible thing. So I'll show you that. So why we don't want a triage system which is conventionally being used, or which we have discussed earlier, that this should be the red, this is yellow, this is the green. Specifically in the mass casualty incident, for example, just think, in your hospital, you are getting, suddenly within next 1 hour, you are getting 150 patients. So will you be able to triage every patient according to the National Triage Protocol or AIIMS Triage Protocol? No, it is not possible, because to triage red, yellow, green, you might have to take vitals. If you are taking vitals, you may take at least 1 minute to triage. You have to take history and a lot of things. So it is not possible in a mass casualty incident to do the conventional triage system, which we follow generally in a hospital. So what happens in a mass casualty incident? So now remember, what are the rules that is to be followed up? You have to, in a mass casualty management protocol or a mass casualty incident, your hospital should have a protocol where you just send the triage out of the emergency unit. So plan a triage point outside the emergency unit. Now, why it is like that? So now point is, this is what is a hospital. I think you can see my slide laser pointer. So this is the hospital unit. For example, this is the hospital. So always put a triage outside the hospital so that you can divide the sickest patient and non-sickest patient before entering into the emergency unit. The reason is that the major problem of a mass casualty incident is the crowd. And I think everyone is well aware of the fact that, yes, obviously the crowd is the problem. So now if you allow every patient entering into the emergency department, then your emergency department is gonna flooded with all the sick patients, non-sick patients, and you'll not be able to do the triage specifically as soon as possible. So we do something called as planning a triage point outside the emergency department. So this is what is the emergency department or the hospital, and plan a triage outside the gate so that you can deviate the non-sick patients to some other area. So now, remember, the priority is to find the severely injured patient, that is called as red patients. Because if red patients are not categorized, segregated, they will die if treatment is delayed. But for the 80% green patients, even if you do nothing, they will create noise, they will acquire the space, they might use the resources, but they will not die. Likelihood of dying is very less among the green patients. So that's why we have to prioritize the red patients here, those 20% of the patients. Now, again, plan a triage point outside the emergency department. What is the triage then? We have been discussing red, yellow, green, red, yellow, green, red, yellow, green. But in the mass casualty management, I am giving some different concept that you have to do two-step triage. So first thing, what are we doing? Before that, you should know what is the hypothesis. Remember that seriously injured patients most probably won't walk. So now what does that mean? So any patient who is coming they may be coming walking to the emergency unit, or they may be coming on a stretcher, on a wheelchair, on an ambulance, who cannot walk. So what is the most important?
Sir, you are mute.
Yeah. Am I audible now?
Yes, sir. Yes, sir.
Yeah. So now what I was discussing is about that seriously injured patients most probably don't walk. That means if I do a triage on the basis of that whether the patient is walking or not, you might have a simplified triage criteria to segregate the sick patient, red patients, from a non-sick, that is green patients. Now, that is called as step-on triage. So what do you mean by step-on triage? Step-on triage is something where the triage is outside the emergency unit. This is the emergency unit. This is another area outside the emergency unit, that is called as step-1 triage, where the patients, when coming to the hospital, will be divided into walking or a non-walking patients. Now, anyone who understands the concept of simple sorting of walking or non-walking can act as a triage in charge. So now, the point is, who will be the triage in charge? Who will be doing the step-on triage? Anyone in the hospital can do the step-on triage. It may be a nursing officer, it may be a security guard, it may be a hospital attendant. But yes, obviously the person should be of the hospital so that he or she can direct the patient walking to walking zone, non-walking to the non-walking zone. Now, you may be thinking that step-on triage is not perfect. Obviously, it is not perfect because walking patients may not be always red. There is a patient who has come with a ankle sprain, for example. The patient will be coming non-walking. So now point is, if you are deciding that this patient is a non-walking, sending him or her to the emergency unit might overload the emergency unit. But see, remember that once you are getting those patients into the emergency unit who have an ankle sprain, for example, who is a non-walking patient, you can obviously do a step-2 triage according to the national triage protocol which you have discussed, and you can go ahead with the sorting later. So frankly, step-1 triage is not perfect. Under triage and over triage will always happen. But remember, why are we doing the step-1 triage? To segregate that 80% walking patients who are green patients outside the emergency department, so that 20% who are non-walking can get care in the emergency unit. Now, there is another possibility that the patient who has gone walking to the green zone, or for example, here in the step-1 triage, there is a patient who has come maybe walking. Now, the patient has gone to the green zone and there is a stab injury in the back. Obviously, the patient may be vitally stable, may be walking at that point of time, may be shifted to, as the patient is walking, the patient may be shifted to a green zone because of the step-1 triage. Now, there should be some another check that those patients should be initially evaluated, again triage to be done. So, what I was discussing is like step-1 triage is not perfect. There must be something that is to be done that is called a step-2 triage. We'll discuss. Now, who should work at the triage point? Reiterating the fact that the triage area or the triage 1 or the step-1 triage should always be located outside the emergency unit with the following people there. One is triage in charge, one is triage assistant. Frankly, triage in charge can be anyone, triage assistant can be anyone. The basic thing is the person who is posted in step-1 triage should be able to decide only one thing. Patient is walking, patient is non-walking, nothing else. No need of getting the name of the patient, no need of getting the date of birth of the patient, no need of getting anything of the patient. You just have to decide whether the patient is walking, send him to the walking or green zone. If the patient is non-working, send him to the red zone or a non-working zone. So whenever the mass casualty management button is activated, you have to decide how you are planning to activate the MCM. The triage in charge will wear the high visibility vest. There must be some uh, yeah. So you should wear the high visibility vest, moves to the triage point. There is something called as triage kit. Triage kit is something where you have to have some basic things needed for doing the triage, specifically the vests, the triage bands, and the admin kit or the something called as, you have to just have a document where you will just mention how many patients who have entered working, how many patients who have entered non-working. Now, here one more important point is whenever the mass casualty is activated, the triage 1 staffs should not leave the triage area because that is the most important area and the crucial area of MCM activation of the hospital. Whereas there must be someone who is a triage assistant to the triage in charge, and he will be doing the same thing. He will be just helping the triage in charge. Specifically here, we have written that they will be assisting the triage in charge in ensuring that each patient has an ID and MCI folder. It is your choice how you are going to do that, but specifically each patient should get a number. So how we planned in our IMSS trauma center is when there is a step 1 triage, in the step 1 triage, any patient who is entering the emergency department will get a white color band with a number. Number 1 patient entered, walking. Number 2 patient entered, walking. Number 3 patient entered, non-working. Send him to the red zone. Number 4 patients, non-working. Send him to the red zone. So now point is that there must be a white color band which is used in the step 1 triage. Please remember, here we are just describing or dividing the patient or segregating the patients into walking, green, non-walking, red zone. But we are giving a white color band with just sequential numbers. Now, why are we numbering? We are numbering because you may not have time to create documentation system, work with the existing documentation system. So just numbering them might help them in tracking. Patient 1, for example, patient has been shifted to green zone, and then what is happening to that patient. So you can go ahead with that like that. Triage assistant helps the triage in charge to direct the non-walking patient to the emergency unit, walking patients to the green zone. I'll show the flow diagram so that you will be clear about what happens in a triage 1. So what happens at the triage point? See, this is where the triage 1 is located. This is the triage in charge. Once the patient enters, the red patient who will be likely non-walking will be shifted into the emergency unit, which is called as red zone. All other patients who are coming walking will be shifted to the green zone. What happens at the triage point? The security must be there to ensure the crowd control. All the patients should receive an ID or folder. So now this is what I was discussing about. White band with sequential numbers or a necktie or ID card with sequential numbers. This is necessary so that you will be able to track the patient, and there is something called a triage kit. So what we did and what we recommend is like you prepare a triage kit, just a small bag where you will be having maybe triage vests, action cards, specifically these triage bands. And if at all you are deciding that you are giving a folder or paper to the patients who are entering, walking or non-walking, you can use that. So it is your administrative policy what you plan to. Now, third thing is all the porters or the stretcher bearers should be available at the entry point. Frankly, the hospital attendants who are inside the emergency department, who are maybe available in the hospital, should always be directed to outside near the triage 1 point so that they will be able to enter the patients with a stretcher. No patient relatives should enter the emergency unit once mass casualty incident is activated. Please remember that. If you are allowing the patient relatives, then obviously you are not gonna able to do the normal processes of MCM. So now the porters or the stretcher bearers should always be available because they have to transfer the patient because you are not allowing the relatives to
The
enter.
computer room plus room.
Okay, any question? Okay, so there must be someone else who is called as admin staff. You can use any other staff, for example, a data entry operator, a hospital attendant, again, to keep track of the patients. 1 number patient working, 2 number patient non-working, 3 number non-working, 4 working, 5 non-working, 6 working, like that. Now, triage kit is something which I was discussing, that the triage bands, which is white color here, sequentially numbers should be there, action cards, because obviously when mass casualty incident or MCM is activated, no one is pretty sure what is to be done. So you have to have an action card so that you can send a triage officer outside and they should be knowing that what is to be done. Now, what have we discussed? We were discussing about what are the types of triage. Obviously, there are a lot of triage, including the national triage protocol, which we have discussed. Why triage is important? I don't think I should reiterate, re-emphasize that why it is important. Now, what is a step 1 triage? Where it should be located? First, it should be located outside the hospital, outside the emergency unit, not outside the hospital. Who can do? Anyone can do, who has a simple knowledge of whether the patient is walking or not. How it is to be done? Nothing. Walking, non-walking. Now coming to what is step 2 triage then. Now what I was discussing earlier is any patient who is non-walking is not always red. For example, a patient of ankle sprain must have come with a non-working category, but he or she may be very stable. He may be shifted to green zone and can be discharged. Ki ankle sprain, you go back home. Similarly, so this is a wrong thing. So we have to have a second, second safety net, that is called a step 2 triage. Similarly, something can happen in the green zone also, that the patient who has come walking with a stab injury or a knife on the back. So now those patients should be directed to the red zone. So now, obviously, as step 1 triage is not perfect, you have to do something called a step 2 triage. And step 2 triage is recommended that whatever triage protocol you are using in the emergency department, for example, we are discussing about National Triage Protocol, red, yellow, green, or AIMS Triage Protocol, the same thing. So these conventional triage protocols should be used to categorize the patient in the step 2 triage. I'll discuss that. Let's see. So now, this is a patient who has come. T1 is the triage 1, the triage point outside the emergency unit. Now, this is where the patient has come. Now, here your step 1 triage officer has decided the patient is walking or patient is non-walking. What happens then? There is something called as gray thing. For example, a patient who has come with amputated, maybe decapitated. The patient has no neck. Obviously, the patient is dead. Now, if the patient is dead, what should be done? Step 1 triage officer should have a very clear idea, working or non-working. Obviously, the patient who had a decapitated head, obviously will be non-working. So this all patients will go to red zone. This all working patients will go to green zone. Now, once the working patients goes to green zone, what happens? There is something called a step 2 triage. So once the working patient goes to green zone, initially the patient should always get a triage, which is called a step 2 triage. So what do you mean by step 2 triage here? As per the National Triage Protocol, here once the patient comes walking, you have to have a system, nursing officer, resident doctor, who is normally doing the triage to again do the conventional triage and decide here whether the patient is red or green. So now the step 2 triage is done on the starting of the green zone. And then the patient, if is a green, the patient will be sent to the green zone. If the patient is red, the patient will be sent to the red zone. Just see here that yes, there is a triage 1 again. Triage is outside the emergency department. The patient has come as a non-working patient. Now the patient is red. If the patient is red, the patient should get all the resuscitation done, basic airway, breathing, circulation, disability, basic secondary survey. You have to stabilize the patient. And then once the patient is stabilized, you do the step 2 triage. Again, once the patient is stabilized, for example, the patient has come with shortness of breath, non-working. Patient is hypoxic. You have come, you have taken the patient to the resus bay. Now, obviously, the patient is red. Now, what you will do, you just see that there is a pneumothorax, put a needle thoracostomy, put a chest drain. Now, patient is completely stable. You do the step 2 triage. Once the patient is completely stable, you have to decide whether you are planning to keep the patient in an ICU or OT, whether you are shifting the patient to the ward. So now, after step 2 triage, if the patient is still sick, the patient will be called as red triage category as per the conventional triage only. So the red triage patients will be shifted to 2 places, either ICU or operative mode. The patient may be yellow. Yellow patients are those patients who you must have discussed earlier that Tetsar has discussed that yellow patients are those patients who are not requiring OT or ICU, but require observation or may require OT or ICU maybe within few hours, but not now. So these are yellow patients. There are some patients, for example, body parts or the patient who are dead will be deceased, which is here we have color coded as gray. So you have to clearly have a delineated pathway, which we will discuss later, how you are shifting the patient, dead patients. There is one category which is called as blue. Now, apart from the concept of step 1 triage and step 2 triage, I request all my participants to think of something called as blue category. So, for example, just take an example of a patient who has come as a non-working. He is a 48-year male. There was a bomb blast. He has come. He is alive, but GCS is 3, E1, B1, M1. his breathing pattern is very slow, for example, maybe 8 to 10. So that patient is someone who is gonna die. Now, where to keep the patient? Obviously, the patient is red, no doubt. Are you planning to shift the patient to the OT or ICU? I don't think so. The patient is gonna die by any means. Are you gonna shift the patient to the yellow area? I don't think so. Obviously, the patient is gonna die. Those patients who are going to die should not be kept in the resus bay because you have to have space for taking more patients inside. So please be clear whenever you are in a place where MCM is activated, resus bay should be completely empty. Now, the patient who has come who is in the extremist condition that the patient is likely to die within few minutes or hours, you categorize them as a blue patient. Now, where to send these blue patients? You have to decide. Usually what we have decided is we'll send them to the ward. The ward will act like a palliative care ward where the patient will be given just fluids and the patient will die. And once the death happens, we'll make the death certificate there. So now remember that. Again, this is where my whole summary is. Patient has entered triage 1 outside the emergency unit, walking or non-walking. Walking patients will get a triage 2, just entering the green zone. Here if the triage officer of the step 2 triage decided that the patient is a red patient, the patient will be shifted to the red zone. Otherwise, green zone will be the lower priority patients. In the triage 1, any patient who is non-working will be shifted to the red zone. In the red zone, after resuscitation, there will be something called as triage 2. If the patient is red, obviously patient will be shifted to OT or ICU. If the yellow, patient will be shifted to ward. If the patient is blue category, who is likely to die, so anyone who is unmuted, please mute your mics. Sonia ma'am, please mute your mic. Okay, so now red, yellow, blue, who is gonna die. So we'll just give a palliative care, but don't keep the patient in the resus bay. And the patient who is dead will be shifted to mortuary. Now, again, why triage is so important? Again, I am showing the same thing at the triage point. Walking patients, green zone. Once green zone job is done, discharge. Non-working patients, here they will be sent to the red zone. Obviously, red zone is the place where the whole emergency unit is the red zone. Red zone patients will go to operation theater, will go to ICU, may go to wards, maybe blue or yellow category, may go to wards if at all you are deciding. There are patients, obviously, who are dead. This B means dead patients. So obviously, dead patients will go to the red zone and then the doctor has to decide that, yes, this patient is dead. Now they will be shifted to mortuary. It is the hospital policy that how you're going to handle the body parts. You may be thinking that this might not be a possibility. For example, body part ka kya karna hai? But the point is, whenever the mass casualty management is activated, you might get body parts, single hand, single limb, just head, body parts. So you have to decide how the pathway is. From the triage point, you are going to send the body part to the morgue or through the red zone. So now there are a lot of other departments who are involved, specifically the forensic medicine, mortuary people. How are we gonna do the management of the body parts or the non-working patients or the deceased patients or the dead patients? So now, another very important thing is following the rules. Step 1 triage should always be outside the emergency unit. Step 1 triage should always be near the red zone entrance. Now, the reason being, obviously, if you are doing a step 1 triage, working or non-working, it should be always near the red zone so that non-working person can be shifted directly to the red zone and can be resuscitated. Because our decision was to send or to save the patients who are red. Now, the green patients should always, green and red flow should always divert. That is what is very necessary. Media and families should ideally be diverted away from the step 1 triage. No media person, no family relatives should enter the emergency unit or any of the red or green zone, because if you are allowing any of the family relatives or media personnel, you will not be able to do your clinical job. So frankly, always remember that if there is a direction of traffic is like that, there must be a step 1 triage. Green should go out, red should go out, means they should divert. No patient should be allowed, patient relatives should be allowed. the media and the family zone should always be away from the clinical area. So now, coming to the end of my talk, just think, just go through this slide. I'll give you a minute just to think what is step 1 trias and what is step 2 trias. And just have a thinking for 1 minute, and then I'll discuss the points here again. Okay, so the point is what I was discussing about is the same thing that is described in this slide. Step 1 trias, how long it should take. I think everyone must be aware of the fact that step 1 trias is whether it is walking or non-walking, it should not take more than 5 seconds to 10 seconds. Simply see the patient walking or non-walking, nothing else. What if it takes 1 minute per patient? No, it is dangerous. Whenever there is a mass casualty management, MCM is activated, you may not be able to gauge what number of patients are going to come. 100 patients coming in 10 minutes. Do that. Is it possible that you can do triage for 1 minute? So obviously the second point is impossible. So how long it should take? It should be done as soon as possible, maybe in 1 second or 2 seconds or 5 seconds. Why are we not using any scoring systems? Obviously, it is going to take time. Why not all red patients are red? All red patients are not red here. The reason being, all non-working patients may be red, may not be red. For example, I have discussed like a patient who has come with lower limb fractures or a patient who has come with ankle sprain only. Obviously, the patient will be non-working, but may not be red. So step 1 triage is not a perfect system. What if a working patient has lost his arm? Yes, obviously, if the working patient has lost his arm, the patient may be bleeding from the left. For example, my left arm is amputated. The patient is bleeding from the arm, but the patient has come walking. So now, in step 1 triage, frankly, the patient will be shifted to green zone. In the green zone, step 2 triage will be done. The resident doctor or the nurse will see, no, the patient is bleeding here. Shift them to red. That's why this is the problem of step 1 triage. So you have to have second safety net that is called as step 2 triage. So now, step 2 triage, where it is done? It is done at the entry of green zone, but in the red zone, it is done after resuscitation. After ABCD stabilization and assessment and stabilization, you should do step 2 triage. So where it is done specifically in the red zone and green zone separately. In the green zone, just at the entry of green zone. In the red zone, after assessment and resuscitation. Who should do it? It should be done by the clinical team. Here, you cannot use a hospital attendant or a security guard. It should be done either by a nursing officer or by a doctor who is well versed with your institutional normal triage protocol. For example, red con hai, yellow con hai, green con hai. So he or she is the person who should do it. Usually in our trauma center, it is the nursing staff. So yes, obviously the nursing staff or the clinical team will be doing the step 2 triage. What happens after the step 2 triage? In the red zone, after step 2 triage, red patients will be shifted to OT or ICU. Yellow patient will be shifted to ward. Blue patients who are expectant will also be shifted to ward. Usually, we don't get green patients. If there is a green patient will be shifted to green zone. But just see what happens after the step 2 triage in the green zone. Again, the same thing. Red patient will be shifted to red zone. Yellow and green will be managed like yellow will be shifted to ward and green will be shifted to the green zone and care will be given. So just checking the agenda, what are the types of triage done? Why it is important? What are the steps of triage, step 1 and step 2? Now I am going to just give a brief idea about what is a triage kit. It is very important that you should go back and make a triage kit in your department. What is that? So what is that? It is the equipments and supplies to support the triage 1. Specifically, the step 1 triage should always be supported by the triage kit. So what should be there in the triage kit? I'll just go through what is there, what is to be done in the triage 1. In the step 1 triage, The patient has come, walking or non-walking, we don't need anything. Now, there is a triage nursing officer or the triage in charge. So he or she should wear a vest. So triage kit must have high visibility vest. Triage assistant should have a high visibility vest. Now, once the patient enters, the patient should be tagged. So that should be white tagged, maybe fita wala tagged, for example, the ID card wala tagged, or there may be triage, there may be band. But it should be white color. Please remember, in the step 1 triage, white color is needed. Why are we giving white color? The reason being it should not be confused with the normal red, yellow, green category. In step 1 triage, white color band is used where it is numbered. So it should be available in the triage kit. Third thing, the patient is entering, someone must be tracking. So there must be tracking seats available. Just numbers. एक number patient, कहाँ गया? Second patient walking, कहाँ गया? Third patient कहाँ गया? Like that. Now, another thing is needed is like always have an action cards. We have our protocol where we have decided what action cards are needed. I have shown it in the presentation and we'll be sharing that also. Now, action card means what is the job of triage assistant, what is the job of triage in charge, what is the job of security guard, what is the job of admin staff who is just tracking the patients. So frankly, triage kit should have, and maybe sometimes the headlamp and all, because if the mass casualty is activated, the electricity is gone. So maybe you may have a headlamp also. So what all things are needed in a triage kit? Specifically, high visibility vests, action cards, tracking seats, triage bands, but the color of the triage band is white color, which is sequentially numbered, and maybe action cards. Other supportive things like headlamp or torchlight, which may be needed as a part of MCM. So that's all from me today. So we have covered almost everything. Please go back and think how the MCM triage is different from the normal triage. Dr. Tej has discussed about the normal triage system, which is really the step 2 triage of the MCM. But I wanted to specifically focus on step 1 triage, which may look very simple, working, non-working. But that is the most epic, apical, and most important thing that is necessary is the step 1 triage. So that's all from my side. So thank you, everyone. Any question?
Thank you, Ankit. Thank you. So now you are more aware that you require two kind of triage. One is to quickly segregate the people into two parts or two halves of the hospital or two places at least. And I told in the initial first presentation that during MCM, 80% will be those who are having minor illnesses. 80-20 rule. And 20% will be those who are having some kind of illness or sickness which requires immediate or urgent kind of care. So just by doing walking and non-walking, it makes the things much easier. So you must remember all those important point, what was told by Dr. Ankit. And I hope in coming time, we will see that all of you are having that kind of plan and your people are aware and trained on T1, T2, triage, MCM protocol in coming time. So thank you very much. If you have any query, questions, you can just put in chat box. And Rupa, if any query, any questions?
Yes,
So I am
sir.
also checking any specific questions.
Yeah.
So you can
So
just
far, we
raise.
don't have any question. We encourage everyone. So if you have any question, and first of all, thank you very much, Dr. Ankit, for sharing an insightful presentation and moreover on time, less than 30 minutes. So thank you very much, sir. It was most apt. And I request everyone, even we are more than happy, dear friends, as we are so happy to see your mass presentation in this evening sessions. Yeah, Manjushri ma'am, I request you kindly share your question in the chat box. Yeah, Brinda ma'am, we are actually recording these sessions on the YouTube. So you can at any time refer our YouTube channel and you can share. I'm just sharing that link here. So please feel free to refer YouTube. I'm so sorry. Unfortunately, we are unable to share the PPT because of some, not having email, and there's a bulk of email, and team is already over occupied with so many things. With that, thank you very much. If any question, please feel free to write. Thank you very much. We are so happy, and we thank you on the behalf of Dr. Ankit and the whole WHO
Just one
team.
question is there, Luca.
Yes, sir.
Yes,
What is the
yeah, I'm just going.
difference between black and blue? Ankit, do you
Yes,
want to take
tag
it?
patient.
Yeah, sir. Anvesa Ganguly ma'am has asked, I think, what is the difference between black and blue tag patients? So now the point is, black patients are the patients black. It may be anything. So whatever category or color you give for a dead patient, that is okay. So we usually give in India, it is a black tag patient. So black tag patients are the patients who are dead. So there is no carotid pulse, patient is dead. The patient will be sent directly to the mortuary. Now, what is a blue tag patient? Blue tag patient are the patient who are gonna die. Means the patient is having a carotid pulse, the patient is breathing, is or are gonna die maybe within few minutes or hours. So now why are we tagging them as a blue? Can you send a alive patient who are gonna die to mortuary? I cannot. It's not possible. So that is first thing. So they are blue tagged. So that's why there is a different category. Second thing, where you will send those patients to. Blue patients will be sent to a ward where just palliative care will be given, that the patient is gonna die. Just we have to respect the human rights. Just give a privacy. So those are the patients who are blue patients. Black patients are currently the dead patients are black. Currently the patient who are gonna die is a blue patients. So that is what I think I am able to clear the doubt.
Yes, that's true. If you are having body parts, dead patient, send them to mortuary. Those who are expectant, earlier we call it as gray, it is same blue. So send them to ward, and then from ward they will be disposed accordingly. So you cannot keep them in emergency because there is no action to save life, limb, or organ, or they cannot be discharged. So anything which cannot be discharged, anything which does not require any active life, limb, or organ saving treatment, they should not be seen in ED. They should be shifted either to ward, dead to mortuary, and those who can be discharged to the green. Another question is walking, non-walking. Why not to give some treatment? If you will start delaying by 1 minute in each patient, let's say you are having 100 patients lying outside the emergency department, so it will be chaos, and probably your hospital is going to be burned out, because in chaos nobody will listen you, they will just push you and enter inside the hospital. So we just try to distribute by putting T1 triads, just distribute them to the relevant spaces or areas so that it can be tackled in nice way rather than keeping all patients at one. It is similar to having a cinema ticket distribution from one counter. आप सोच लो, याद कर लो, just remember, है ना सारे, if you will distribute 100-200 people's tickets from 3 to 6 वाले मूवी का, so क्या होगा वहां पे? chaos, मारपीट हो जाएगी. That's why we just want to distribute to various areas by T1 triage, no treatment will be given there. Okay, so T1, then formal triage, that is the T2 triage in both the places, red, green, and then treat, discharge, treat, admit. Don't require that kind of great treatment in ED, just shift to ward. That is yellow. So that's it. Okay, so thank you very much.
Yeah. So there is another question. May I? So Dipta Bhattacharya ma'am asked, in step 1, it is necessary to identify walking and non-walking, but along with that, necessary treatment is to be given before sending them to OT or ward.
That is what I was telling, Rupa. I was telling that no treatment at all. If you will start,
sorry, sir.
If you will start even examining the wound,
Oh.
it is bound to have chaos outside the hospital, and nobody will listen you. All system will be collapsing. So just at T1 segregate, right, left, walking, non-walking. That's why. Okay. Thank you.
So sorry. Yeah. Thank you, sir. Thank you very much. Another question is, if it is a rescue shelter in MCM, what would be the procedure? Is it triage going to be the same?
See,
If there is,
idea of triage is to segregate the people in various zones so that it can be tackled in useful and nice way. So just distribute the population, and wherever you are distributing, it should be in a categorical manner, like walking, non-walking, then green, red, all yellows to what. So that's why it can be done in centers also, where you have one corner where you can do minor procedure. So just separate one to another shelter area. Those who are very sick and requires immediate management can be sent to one place. So that is how it works. Okay. One more question is there, like, can it be practiced how to manage this in health sub-center level? So at health sub-center level or PHCs, you don't have that much of space. If you have a space nearby, what you can do, you can manage the green there itself. If you have a space, or arrange some additional space. So if you have some manpower, if you have some space, start managing those patients. But rather more important to act as a wellness center staff is to do good triage and send those patients who require treatment urgently or immediately to other facilities or nearby facility, rather than keeping them and managing there. So it will be very difficult to accommodate a lot of patients at your place. Maybe 10, 20 patients, you can think like that. But may not be right for 100, 200 patients at wellness center or PHC even.
yes, sir.
Sometimes the
Sir,
non-walking patient may not serious. So what is next step? Put in green. So non-walking patient, suppose non-walking, they went like ankle sprain, they went to red area. So you will do formal trials again there. So if you find them green, send them to green area. That is how it works. That's why we have two steps of triage, T1 and T2. So even walking patient can have a stab in chest or some splinter injury in chest. So if you find he may be sick or likely sick, then you retriage them and send them to red area or red zone. That is how it works. No, probably Sudipta madam, probably we have misunderstood. We are not going to stabilize in step 1. Step 1 is at gate, just walking, not walking. Okay. Okay. Yes, we are going to have a series of webinar on mass facility management. So few more lectures will be there. Okay. Thank you. Thank you very much. Over to you.
Thank you, everyone.
thank you, everyone. So see you on Wednesday with a new topic. And all the very best. Take care. Bye-bye.
Bye.
Thank you, Ankit. Thank
Thank
you,
you,
Rupa.
sir.
Thank
Thank you
you.
once again. Thank you, sir. Thank you,
Thank
Dr.
you.
Tej. Thank you, Dr. Ankit. And thanks all the participants